Hi, I'm Dr. Randy Martin, and welcome to the AATS 2017. I'm thrilled to be here now with Dr. Bob Bonow. Bob, you've been giving the honorary cardiology lecture at this fabulous job. So, how do we manage patients with mitral regurgitation in 2017?
Well, great question. I think what we're really focusing on currently is getting a team together. I mean,
Okay.
it's still a team sport when we're dealing with our patients with valve disease, mitral in particular, because of the nuances
Right.
about when to refer for surgery. So the key is to have a surgeon and a cardiologist, a non-invasive as well as an invasive cardiologist, good nursing staff, and then all the other people who become really important in the team, anesthesiologists, social workers. We've been successful in putting that together. I think that's the key for moving forward.
Bob, and you've been instrumental in almost all the guidelines, the valvular guidelines. Is anything changed since the 2014 guidelines in the mitral space?
Well, we just came out with a 2017 update.
Okay.
A lot of that was driven by all the excitement with TAVR on the aortic space, but there's some new things in mitral as well. Still focusing on trying to push the envelope on the asymptomatic patients.
Okay.
We've always said that it's a kind of a 2A recommendation if you've got the right patient and the right surgeon for a cardiologist like me to refer a patient with severe myxomatous mitral valve disease that's repairable.
So primary.
Yeah, I mean, it could be a class 1 in some centers. It's a class 1 for me, but we do see variability both in the way that surgeons behave and the way that cardiologists behave nationwide, that we still want to put a little bit of concern out there that this is not an open season that we're going to operate on everybody, but in the right patient and the right surgeon, it really should be considered almost a class 1. The new thing in the guideline is that if we're following a patient and there are progressive changes in either left ventricular size increasing or ejection fraction decreasing, also consider that, even if the patient otherwise would not be considered a surgical candidate.
Is that different than the 4 centimeter and 65%? I mean,
I think
you're coming down and
that's the point. That again, a patient with severe MR would be a candidate for repair independent of the ventricular size or function.
Okay.
However, if you're using a threshold of 60% ejection fraction or 40 millimeter end systolic dimension, the point we're trying to make is don't use those as hard endpoints. The patient's progressing with a decline in ejection fraction toward those endpoints, or an increase in end systolic dimension, maybe 36 going to 38 if it's good measurements. Consider this patient perhaps as progressive and consider for earlier surgery.
Bob, it seems to me, and historically, that cardiologists have been slow to refer patients. I mean, I know when I speak to surgeons, they say we don't get patients till they're really end stage. You feel that there's an awakening among the cardiologists to patients are always going to say, look, doc, I'm asymptomatic.
Yeah, I still think there's a slow awakening. I think that's one of the issues. I'll be getting into that in my lecture today, that we kind of focus on the variability in what surgeons do and how there's many surgeons who don't do many repairs. Well, there's also some major issues in cardiology about how they manage patients. They know the guidelines, they've got experience. I think the issue is that many of our patients are being seen by not only primary care physicians who aren't aware of the recommendations, but also cardiologists. We're very busy people, excellent doctors, taking care of acute coronary syndromes and heart failure like bread and butter, but they're a little bit less familiar with what the recommendations are for valvular heart disease.
Bob, what about, and still talking about primary MR, asymptomatic patient, role of exercise testing? Is that getting increasingly important?
In my practice, it is, and I think we're looking for some good data to actually hang your hat on to say this should be a stronger recommendation in the guidelines. But I think clinically it's very important. First of all, is the patient who says he or she is asymptomatic really asymptomatic or not? So watching how they do on a treadmill can be quite helpful. But also, as you know from your own work, looking at the hemodynamics with exercise.
Absolutely.
Is the pulmonary pressure going up? Is the moderate mitral regurgitation become more severe with exercise? That might explain why someone who doesn't appear to have severe MR has symptoms. Maybe there's a hemodynamic reason for that you can bring out with exercise.
And you've emphasized that in an asymptomatic patient, the experience of the surgical team is really important. Let me just finish with, do we have anything new in secondary MR, the quandary of secondary MR?
Well, the quandary has gotten more of a quandary based upon the clinical trials we've seen. So here we got finally randomized clinical trials, but they've kind of thrown somewhat of a monkey wrench into the works here because they were somewhat counterintuitive. So we do have some new recommendations that are 2A and 2B regarding functional or secondary MR. One is if the patient's a candidate for surgery, either because the MR is severe or the patient's in the OR having a cabbage and you want to fix the valve. There's kind of a mix now as to whether you would repair that valve or replace the valve.
Right.
So in some settings, a chordal sparing mitral valve replacement would be reasonable.
Right.
And maybe get more long-lasting in some patients and some surgeons than a repair. That was one new one. The other is based upon the data in the second NHLBI trial of moderate MR, and that is whether you would repair the valve or not at the time of cabbage.
Right.
And so that's kind of a 2B. Consider, but remember there's some data from a randomized trial that with moderate
cabbage.
MR. But the real issue for secondary MR that you're aware of is how do we define severity? It's a very difficult lesion to assess, especially with echo, as to how severe effective regurgitant orifice may be.
And it changes.
And it changes, yeah.
Unbelievable.
Depending upon medical therapy, blood pressure, fluid status. And so it's I think that's our issue many times, is when does this patient have severe enough MR that all of our medical therapies have not worked and it's time for surgery.
So do you think we're getting in a better spot then with primary knowledge-wise than we are with secondary?
The knowledge base is growing. I think the primary MR database is pretty well set, although where the percutaneous techniques fit in is still, I think, unclear. That's another moving target, rapidly moving target. But for functional MR, I think we still need to get our arms around how we assess patients, what are the indications for intervention, and then is our intervention going to be a surgical mitral valve replacement or repair, or is it going to be a transcatheter replacement or repair?
Stay tuned for the future. Listen, you've educated me always, and thanks very much for being with me.
Thank you, Randy.
And thank you all for joining us.